Good morning, ladies and gentlemen. We are open at a symposium organized by CVRF and supported by educational grant from Medtronic Korea. The title of this symposium will be a case-based approach to complex PCI. My name is Myung-ho Jung from Jeonnam National University Hospital, Korea. We have three panelists, four speakers today. We have panelists Jung-soo Kim, Young-min Woo, Young-won Yoon. Would you please introduce Dr. Jung-soo Kim?
My name is Jung-soo Kim from Busan National University Hospital. It's good to see you. Thanks for inviting me. I will join this session.
And Dr. Young-min Woo?
Hello, I am Young-min Woo from Gangneung Asan Hospital. Thank you for inviting me. Thank you.
And Dr. Young-won Yoon?
Hello, my name is Young-won Yoon from Gangnam Seoul Hospital. Thank you.
And we have four speakers from Korea, Japan, and Australia. I'd like to introduce first speaker, Dr. Kyu-chul Oh from Catholic University, Korea, St. Mary Hospital. The title of his lecture will be Road to Successful PCI by Presenting with Resonix. Dr. Oh, please.
Hello, thank you for the introduction. My name is Kyu-chul Oh, and today I'll talk about the Medtronic Resolute Onyx stent and that which will aid us in performing successful bifurcation PCI. I was asked to share some cases on bifurcation PCI, and I think I've made a too grand title here, but I think if you hear what I have to say, you might pretty agree with me in the end. My disclosures. But first, I'll briefly talk about the features of the Onyx stent that might help in performing a successful bifurcation PCI. And then I'll share some cases in my clinical practice. One's a LLE bifurcation and one will be a left main bifurcation case. Bifurcation PCI may be easy for the experienced, but for people like me, it's not what I want to encounter every day. Luckily, better stents, balloons, extension catheters, which the next speakers will talk about, have helped reduce the time and effort in bifurcation PCI. When we encounter a bifurcation that needs stenting, we want our stents to have certain capabilities. We are now all aware of the importance of the proximal optimization technique and kissing ballooning. So when we perform these procedures, we want precise deployment of the stent, minimal deformation when we expand that stent, and easy crossing through an already deployed device. And luckily, the Onyx stent has the following features that help us in each of these steps. I'll go over them, but they have a very visible iridium core, which makes them visible and have aid us in precise deployment of the stent. They have rounded struts, which make devices more easier to pass. There's an adequate cell size, and even they have a very wide portfolio, enabling us to put the stents in adequate vessels. And it's made out of a single wire design, which supports very flexibility and comfort mobility. When we're performing bifurcation PCI, POT is crucial for optimal stent expansion and opposition. We perform high pressure ballooning with a balloon shoulder located just proximal to the carina. We want the stent to have minimal deformities when we do this. The Onyx stent, compared with other stents, as you can see here, have less foreshortening or longitudinal stent deformation, even in high pressure inflations. Compared with other stents, the stent struts are also more uniform when these stents are expanded to their very high limits. This is a 5.0 millimeter stent, which has been expanded to a 5.75 millimeter. Compared to the other stents, they have a very uniform cell strut, even in these expansion areas. You can also see that even after maximum overexpansion, the cells are evenly spaced, which will help in radial strength and minimize restenosis in the future, unlike the other stents. Furthermore, with overexpansion, there may be damage to the polymer coatings on the stents, but the Onyx stent here on the left shows excellent coating integrity, assuring uniform drug distribution and leading to less restenosis. As I mentioned before, the Onyx stent also supports sizes over 4.5 millimeters, and they have lengths up to 30 millimeters. It's a very wide portfolio, suitable for even lesions in big left main vessels or in ectatic vessels. One other hurdle in bifurcation PCI is the crossing the wire or the balloon or the stent into the side branch through an already deployed stent. The Onyx stent strut is very rounded. It's rounded and has an iridium core. Unlike the other stents, which are more squared struts, it also has regular cell shapes, which feature in both of these features that help side branch access after a stent deployment. You can see on the left and on the right here that there's when you try to pass a second stent through already deployed stent. In the left, the Onyx stent, it's very smoothly moved through an already deployed stent. However, in the right here, there's resistance and stent deformation here on the right. Additionally, as the Onyx stent has a central iridium core, as I've mentioned before, it's very easily visible by fluoroscopy compared with other stents, as you can see over here. And these two are one of my cases that I did. They are both in both cases, I'm trying to deploy a stent right on the diagonal ostium, but there's already a stent in the main branch in both cases. You can see here, the left one here is a stent that is very known to be nearly invincible. And you can see that it's much easier to see where my Onyx stent is going to be compared to the left. So, well, they are both going to be on the ostium, but in here you can almost see where the Onyx stent struts are going to deploy. When we perform kissing ballooning, we want two things. First, adequate opening of the side branch. Next, we want minimal distortion of the main branch stent. And also here, the Onyx stent, an opening of nearly 4.9 millimeters in diameter can be achieved in a stent size over 4.5 millimeters. So that would ensure enough opening even for big circumflex vessels. And there's also minimum deformation to the main branch stent even when you maximally inflate to the side branch. Finally, after kissing ballooning and after everything has been done, we want good apposition throughout the lesion. So here, the Onyx stent is like a slinky when we were playing when we were very little. It has a single wire design and it is thus very flexible compared with other laser cut stent platforms. It also has a peak-to-peak design, also which prevents it from longitudinal stent deformations. So all in all, these features help the Onyx achieve excellent opposition after bifurcation PCI, regardless of the many bifurcation anatomies that we are going to encounter. To sum up the former part of my lecture, the features of the Onyx stent shown here will aid physicians in achieve optimal results in bifurcation PCI. Next, I'll be sharing some simple cases that I've done. As I mentioned before, I'm a very newbie here in the interventional field, and I don't have a lot of experience, so you'll have to excuse me on that. The first case is of a 57-year-old male. He arrived to the ER with chest pain that started 3 hours ago. He did not have any past medical histories, and his initial EKG showed precordial ST elevation. So he was diagnosed as STEMI, and a prompt coronary angiogram was done. So on the right here, you can see this is I think this was the AP view. There was a near total occlusion of the mid LAD where with the diagonal bifurcation, there was TIMI1 flow and PCI was performed directly. On the left, after wiring to the diagonal branch at the first and ballooning with 2.5 millimeter semi-compliant balloon, I could see that there was a thrombotic occlusion in the mid LAD, and actually there was a very big diagonal and a big, just like a dual LAD, and the lesion was at the bifurcation, but still the ostium of the diagonal seemed pretty okay. So I was going to go for a provisional stenting approach and going to stent the mid LAD here. So I deployed a Resolute Onyx 3.5 millimeter stent at the proximal to mid LAD. There wasn't a full expansion. There was under expansion at the mid, just distal to the bifurcation. So after that, I performed adjunctive ballooning with a 3.5 millimeter non-compliant balloon and which showed a little bit more expansion. But just after doing this ballooning with a non-compliant balloon, the big, you can see here on the right that the ostium of the very big diagonal branch was a bit compromised. And it still had TIMI3 flow, and I was going to stop at this, but at this point, the pain, which has been getting a little bit better, just got aggravated and the patient was in very distress. So I had to open this artery up before I could do any more FFR testing or physiologic testing. So on the right here, you can see that there's an IVUS image after the deployment of the, no, this is the IVUS image of the diagonal branch, which shows a very tight stenosis in the proximal ostium. So before I want to put the stent, this was totally in the middle of the night, so I didn't really want to do a bifurcation 2-stent PCI. So first I did the proximal optimization with a 3.5 non-compliant balloon that I've used before. Still, there was no relief of the pain after that, so I had to put a Resolute Onyx 2.5 millimeter in the diagonal branches, so like provisional T-stenting. Luckily, there was after POD, the side branch struts were very opened up and the stent was easily passed through the diagonal branch. And also this is the image that I've shown you before with very visible stent struts. So you can see here that I deployed the diagonal stent right at the ostium. So after that, kissing ballooning with 3.5 and 2.5 non-compliant balloons, another final POT. And finally, you can see here that I've had, I wouldn't say with 100, I wouldn't say I got 100 points on this, but I'd say I could get maybe 85, 90 points. So afterwards, both the main branch and the diagonal IVUS showed very good opposition. And here you can see that there was a very minimal narrow carina, a metallic carina, which could arise when you do a little protrusion when you do TAP. So that was good. The next case is from, this next case is a similar 58-year-old male. He had underwent PCI multiple times over the span of about 10 years. He had stents in his LAD and in circumflex. 2 hours before arriving to the ER, he started having chest pain and shortness of breath. He was on hypertension medications. He was on insulin for his diabetes. His creatinine level was elevated. He was CKD stage 3. When the first initial exams in the ER, the EKG did not show any ST changes, but his cardiac markers were elevated, and his ejection fraction was near he had a systolic dysfunction with multivessel wall motion abnormalities. Because of the elevated creatinine level, I only got 2 images of his left coronary artery. You can see that there are very many stents in his LAD. I think it was about 3 or 4. He had done them in a different hospital, so I'm not really sure. There's also a stent in the circumflex. You can see here that there's a total occlusion of there's actually a stent here, a total occlusion of the mid LAD stent. And maybe there's some antegrade flow. Maybe it's bridging collaterals, I'm not sure, but there was a collateral flow from the RCA. So I don't think this was really the culprit here. So there was also a little bit de novo progression of his lesion at the distal to the circumflex stent. And you can see here that his main is very significantly narrowed, and there's a Medina 111 left main bifurcation lesion there. So first, I was going to take care of this left main bifurcation and then do a staged PCI for his mid-LAD lesions. So first I did ballooned the circumflex ostium with a 2.5 non-compliant balloon, then the main to LAD with a 3.5 non-compliant balloon. You can see here that on the previous slide that there's another wire here in the diagonal branch. That's because he had a very early diagonal here, which was narrowed at the proximal segment. So we wanted his ejection fraction was so low that we wanted to save all his vessels. So I pre-dilated this early diagonal branch with the 2.5 non-compliant balloon. Luckily, there was minimal dissection and there was good flow. So I was going to leave that there and go on with the main stenting. So here I did the DK crush technique. First, I will put the Resolute Onyx 2.5 millimeter stent in the circumflex ostium and then kissing balloon. I don't have the image for the pot. I did the pot and then the left main to LAD stent with the Resolute Onyx 3.5 millimeters, kissing balloon again, and then final pot. And right here on the image is the final image I have. You can see that's very good. And he later went on to have mid-LAD PCI and is very similar. To conclude, the Resolute Onyx stent design helps us achieve optimal results in bifurcation PCI, but always you have to, when you perform these complex PCIs, you always have to plan ahead, beware of unexpected situations, and be comfortable with at least 2 bifurcation PCI techniques. Thank you for your attention.
Okay, thank you very much, Dr. O. Dr. O presented successful bifurcation stenting using Resolute Onyx. I'll introduce next speaker, Dr. Wonjeri from the Seoul National University, Bundang Hospital, Korea. He introduced about EBC main data update, clinical evidence with Resolute Onyx, the drug-eluting stent. Dr. Lee, please.
Thank you, Dr. Zhang. My name is Wonjeri from Seoul National University, Bundang Hospital. Today, I'm going to talk about EB's main data update with clinical evidence with Resolute Onyx DES. I have nothing to disclose. So we encounter bifurcation a lot of time these days. Bifurcation PCI, including the left main, are very prevalent and complex. So in daily life, about 30% PCI involves bifurcation, and we know that more than 80% of left main disease involves the bifurcation. So the optimal treatment strategy for true left main bifurcation still remains a highly debated topic. So let's look at the recent guideline 2018 ESC. So let me go through some of the text here. So we all know that still main branch only stenting with provisional stenting of the side branch should be preferred approach for most bifurcation lesions. However, this time there was some exception was mentioned. When upfront side branching stent may be preferable, it's the situation when the presence of large side branch, which is larger than 2.75, with a long austere side branch, which is longer than 5 millimeter. And if difficulty anticipated, then upfront to stenting was recommended. And there was one more thing down here as well. In left main true bifurcated lesions, double kissing crush, DK crush, AKA, has the most favorable outcome data. So this was actually reflected in the guideline with the level of evidence to B. So I think everybody here knows DK crush 5 result, and this was the key to be reflected in the change of guideline in 2018. And in this study, even in simple lesion, not just complex lesion, even in simple lesion, DK crush showed robust results compared to provisional stenting. However, I think many clinicians still had some doubts whether we really have to do this upfront to stenting even for simple lesions. So luckily, last year in European Heart Journal, we had good data from EBC. So let me introduce this data today. So this study was for stable or unstable angina patient with unprotected left main bifurcation disease type 111 or 011. And both branches have to be larger than 2.75. So 230 patients in each group, and primary endpoint was composite of death, MI, and TNR at 1 year. Main including criteria was bifurcation distal left main stem stenosis more than 50%, and it has to be true bifurcation, and LAD and circumflex diameter has to be bigger than 2.75. Main exclusion was if it's acute SMEMI, it was excluded, cardiogenic shock, CTO, if purification, and these lesions were excluded from the study. There was quite a detailed description for provisional and systemic dual stent strategy in this article. So for provisional step-by-step layer technique, followed by POT and KISS was mandated. In systemic dual stent strategy, operator choice of technique, TCTAP, kilo, or DK crush were all allowed, but high pressure osteal bifurcation dilation was highly recommended at the end. So I think one remarkable thing about this article was that it has very detailed description for stepwise provisional single stent in the article. So there are some examples such as if side branch predilatation was discouraged, and if kissing balloon size were chosen according to the diameter of distal left main and side vessel respectively. And here's important point, with individual high pressure inflation followed by a final lower pressure kiss dilation. And also, if interventionist wants to do two stenting, then it has to meet one of these following criteria, whether it's TIMI less than TIMI 3 flow, or there should be severe osteal pinching, and if straightened side branch closure or side branch dissection type A should be present, that's when you can do a provisional stenting. Patient characteristics were relatively reflective of our real world. So age was about 70, and 30% diabetes. Since STEMI was excluded, acute coronary syndrome was about 33%. And Medina classification 111 was about 90%. If we look at the procedural characteristics, you can see that POT after first stenting was about 90% here, and imaging was used in 40% of cases. There was also a very detailed definition of technical success. So technical success was defined if the intervention is completed, stent placement, balloon dilatation, rewiring, and final kissing balloon as well. So in this study, technical success was around 90%, but for provisional stenting, procedural success was higher with 97%. So this is a key image here. So you can see that the red line is the same dual, and the blue one is step-by provisional. You can see that there's no difference, and numerically you can see that in each of the components, it seems that it favors step-by provisional here. So for procedural MI, system dual was 5%, whereas stepwise was 4%, and even targeting the revascularization, systemic dual was higher with 9.3%. So why is there difference between EBC main and DK-CRUSH-5? These are summary from what authors mentioned in the article. So the definition in the studies were different. The DK-CRUSH-5 study used cardiac deaths and target vessel MI rather than deaths and MI in this trial. So there is difference in outcome. And the coronary anatomy was different. The syntax score of DK-CRUSH was 31, whereas EBC main was 23. And the side vessel lesion lengths were 16 in DK-CRUSH and 7. And I also agree that this was the main point when those two data were different. So basically, the extent of disease was greater in the DK-CRUSH-5. And indeed, there were 45% of patients going through stenting in provisional group, whereas only 22% in EBC main. And authors also mentioned that the philosophy approach varied between the two trials. So basically, DK-CRUSH-5 was pioneered by Chinese cardiologists, and the step-by provisional approach has been championed by European groups. So authors said that there may have been some unconscious bias, and attention to detail might have been different. Recently, so there was an editorial published regarding this EBC main and DK-CRUSH-5. So again, if we compare EBC main and DK-CRUSH-5, the number of patients was pretty similar. And if you get the prime endpoint, as I mentioned, it's completely different. EBC main, all-cause deaths and MI, whereas DK-CRUSH-TLF was cardiac deaths and TVMI. And also, the mean syntax score was 23 versus 31, side versus length, 7 versus 16, and periprocedural MI definition was also different. So all this difference might have contributed different clinical results of the study. And in this editorial, author suggests that if it's non-complex left main bifurcation, still the provisional stenting is preferred. However, if it's complex left main bifurcation, author suggested upfront 2 stent, and based on the recent clinical data, DK-CRUSH was recommended over QLOD here. Dr. O already mentioned very detailed information of the good features that Onyx stent has, so I will be just brief. So basically, this EBC main was conducted with Onyx Resident Onyx stent. So single wire design, round strut, platinum iridium, all mentioned Dr. O has very favorite feature for bifurcating PCI, and having very big size like 4.5 and 5.0, that's very good for left main bifurcation as well. Recently, the other data has been published regarding bifurcation using Resident Onyx. In this study, there was about 200 patients was enrolled. It was a single-arm study, and primary endpoint was a target vessel failure. Age was about 66, diabetes 30%, acute coronary syndrome about 50% cases, multivessel about 40% of disease. And let me show you the result. So based on best performance goals derived from contemporary bifurcation trials, performance goal was about more than 20%, but in this trial, TVF was only 6.9. And what's more important here is that there was 0% stent thrombosis. And procedural outcome was very high with Onyx stent, reaching almost 100%. So there has been new data supporting the resonance in bifurcated PCI and with EBC main, including the left main as well. And one thing to note is that currently resonance is now the only DES with the randomized data supporting adaptability to provisional and prone-to-stent strategy in left main disease. So let me summarize my talk. So stepwise provisional strategy is a valid option for most left main bifurcated stenting. However, if in highly complex cases, we should definitely consider systemic dual stent strategy. And with the very good features and also the proven data that resonance have, I think it's going to be a good choice for us when we're doing bifurcation lesion stenting, including left main. Thank you.
Okay, thank you very much, Dr. Wonjeri. Dr. Lee presented left main data, update data, especially using Resonance drug-eluting stent. I will introduce the next speaker, Dr. Yoshiyasu Minami from Kitasato University School of Medicine in Japan. He'll give us talk about clinical utility of telescope guide extension for ostial calcified region. Dr. Minami, please.
Thank you very much, Professor Myohonjo. I'm Yoshiyasu Minami in Kitasato University Hospital in Japan. So I want to talk about the clinical utility of telescope guided extent catheter for the ostial calcified region. So as you may know, there are several advantages and disadvantages of OCT and iBurst for the daily clinical practice. And the OCT guided may be better than the iBurst guided for calcified region. Because OCT clearly visualizes the detailed morphologies of the calcified region, and also it enables to assess the requirement of the intensive region preparation using the debarking devices. And also there is OCT-based calcium scoring has been developed and introduced. And this is very useful to identify the lesion with high risk for stent under expansion. So this scoring system consists of several parts. And if the maximum calcium angle is more than 180 degrees, 2 point, and the maximum calcium thickness more than 500 micron is 1 point, and length, longitudinal length is more than 5 millimeter is 1 point. And if the total score is 4 point, that kind of region has a very high risk for the stent under expansion than the other regions with risk 1 to 3. In addition, recently updated OCT system with artificial intelligence automatically identifies the coronary calcium. And these OCT systems provide several metrics and distribution of the calcium during the PCI procedure. So for the lesion with the calcified lesion, we would like to use the OCT than the iBurst. On the other hand, the OCT guidance is not suitable for the ostial region. So as you know, the complete blood removal surrounding the tip of guiding catheter is almost impossible. So for the calcified region, OCT may be better. However, the ostial region is not suitable for the OCT guidance. So if the lesion is an osteocalcified region, which OCT or iBurst do like you to use for the daily clinical practice? I'm not sure the best answer for that question. However, if you'd like to use the OCT for this kind of osteocalcified region, the using telescope is a promising option. So I'd like to introduce the see-through technique for the out ostial observation using the telescope. So among several types of the guide extension catheter, including the telescope, guide regular guideliner. The telescope has a very unique characteristics with a coil structure at around the shaft of the telescope. Then OCT light can penetrate through the tip of the telescope, and also through the tip of the the shaft of the telescope, because the shaft is coil-like structure, and between the coil, OCT light can penetrate. Then we can obtain the OCT images. Then for the PCI, we locate the telescope at around the out ostial junction. Then we can remove the blood cell surrounding the telescope, and OCT light can penetrate through the tip and the shaft of the telescope. Then we can obtain the clear image of the OCT. So this is the movie published in the case report, and as you can see, that we can obtain the OCT images through the telescope. And please don't forget to change the survey mode to the high resolution mode. Usually, I guess you are using the survey mode, which enables the 75 millimeter the scanning. However, frame interval is at 200 micron. So the high resolution mode is the more clear images with the frame interval is 100 micron. So we can get more images if we use the high resolution mode. So these are still images. Then D panel shows the OCT images obtained through the tip of the telescope, and panel E, F, Z are obtained through the shaft of the telescope. As you can see, the image quality is similar or much better than the IBERS. Then these are the 3D reconstructed OCT images. Then as you can see, that we can clearly identify the exact location of the out ostial junction. So this is an actual case in our cath lab. And the patient was 88 years old male with a non-ST segment elevation myocardial infarction. And the lesion is a very tight cultural region at the proximal and the mid portion. And for that kind of case, which IVAS or OCT do you like to use? So because the hemodynamically a little bit unstable, so you inserted the temporary pacemaker and IABP. Then after that, because the lesion is super tight, so first we avoided the calcified plaque using the rotational arterectomy with 1.25 millimeter. And after that, we dilated the plaque again and again. Then after that, we performed the OCT pullback. So because this is a new system, so the pullback is coming from the proximal to the distal. As you can see, we obtained the very clear images. Then we can also see the vessel structure through the tip and shaft of the telescope. So these are still images. Then as you can see, the we can identify the exact location of the out ostial junction. The panel B shows the just proximal side of the RCA branch. And as you can see, the C panel shows a very tight eccentric protruding calcium at around the proximal portion of the RCA. So from these images, we decided to dilate more and more for expand the lesion with the calcified protruding calcium shown in the panel C. Then after that, we decided to put a stent. And because we had already identified the exact location of the out ostial junction by using the angiocore registration, and the yellow circle represents the location. Then by using this image as a reference, we put one Onyx stent to cover the old calcified lesion. Then the right panel shows the final angio after putting the stent. These are still images after putting the stent. So as you can see, stent was well expanded, a little bit eccentric at the side of the protruding calcification. However, we can identify the very good strut malapposition at around the out ostial junction. So these are take-home messages. Visibility of the ostial region by OCT is quite limited because the disability of the light penetration through the guiding catheter and the impossibility of the complete blood removal around the tip of the guiding catheter. However, telescope is a promising option to visualize the ostial region due to the qualified tip and shaft, which allow the OCT light penetration. Thank you for your attention.
Okay, thank you very much for excellent presentation. Dr. Minami introduced OCT intervention for ostial calcified region using telescope. Thank you very much. I'll introduce next speaker, Neil Jackson from Australia, Prince of Wales Hospital. He'll give us talk about high bleeding risk and deep duration after PCI. Dr. Jackson, please.
Thank you very much for that introduction, Professor Yong. So I'm assuming you can see my slides there. I'm going to present a case. It's a bifurcation PCI case. So it sort of extends to some of the issues we've discussed in this session, but in a high bleeding risk scenario. So one of the problems we've had in recent years is, despite a number of high bleeding risk trials in patients undergoing PCI that have been published and give us some guidance, there's significant heterogeneity across the inclusion criteria for these studies, the DAP regimens, and the endpoints. So there's quite commonly very variable bleeding risk in these patients and variable event rates. So it's very hard to compare across studies. So a consensus is being needed. So this is a very important document, and I would recommend people look at this. And it's a consensus document from the ARC Consortium for High Bleeding Risk, published in Circulation and Neurointervention, Philip Urban's first author. And the factors they delineate associated with increased bleeding risk after PCI are clinical aging factors, they're comorbid factors, renal disease, liver disease, malignancy, hematological issues, intracranial pathologies, a history of bleeding and or transfusion, oral anticoagulation, non-steroidals, and importantly, planned non-cardiac surgery on DAP in the short term. So they identified factors, and then looking at the endpoints from studies that had used these clinical entities, they defined high bleeding risk to go forward as BARC 3 or 5 bleeding risk more than 4% at 12 months, or risk of intracranial hemorrhage more than 1% at 12 months. So a consensus of definition to both apply for studies in the future, but it's also very helpful for the clinician facing patients in the cath lab. Specifically, they defined high bleeding risk as at least one major criteria or at least 2 minor criteria. So in dark blue are the major criteria, and I won't go through this in detail, and light blue, the minor criteria. So 75 and above alone is a minor criterion. Renal impairment with EGFR less than 30, a major criteria, less than 60, minor. Major is liver disease, malignancy, anemia with hemoglobin less than 110 grams, thrombocytopenia, intracranial pathology. I won't go through it all. Very important, very helpful data, but again, very important for the case I'm going to show. Non-deferrable, non-cardiac surgery on DAP following recent PCI represents a high bleeding risk scenario. And also important to consider, because I'm going to show you a bifurcation case. This is a proposed algorithm published in Neurointervention late in 2021, and it brings in clinical factors to help dictate duration of DAP after a bifurcation intervention, because we know bifurcation PCI is associated with a higher event rate, both in terms of target lesion failure and stent thrombosis. So the clinical presentation will impact whether it's stable coronary disease or an ACS, as will PCI strategy, whether it's a planned provisional, a planned 2 stent, or the situation where probably the worst clinical outcomes is a bailout stent on either limb. So that will then help drive DAP duration. But very importantly is what is the baseline bleeding risk of the patient. And it introduces a very important concept, I think, is the use of adjunctive guidance to help dictate duration of DAP, particularly when you may be in a high bleeding risk scenario or potentially needing to prematurely interrupt DAP therapy for whatever reason. So if you've got a high bleeding risk patient who's had a single stent strategy in stable coronary disease and imaged, we can go a short DAP, as low as 4 weeks. Whereas if we've got a bailout scenario in a high bleeding risk patient without imaging, maybe we're recommending at least 12 months. So very helpful. So the message here is strongly consider imaging, and not just in complex intervention, but here in a high bleeding risk scenario where we're going to shorten our DAP therapy. So the patient, 71-year-old man I saw late in 2021 with new onset angina, normal ECG, normal troponins, biochemistry was normal. He was referred to me not just because of the angina, but a urologist had found a right renal mass, presumed to be a renal cell carcinoma, and wanted to know it was safe to do a nephrectomy. He at that stage was on no medications, had normal left ventricular function, quite a strongly positive stress echocardiogram suggesting at least LAD territory ischemia. He was placed on DAP and brought to the cath lab. We can see his right coronary artery is a large vessel, non-significant disease, it is atherosclerotic, but on the still frame of the left coronary appears to have a probably significant mid-LAD lesion. So we can see in the AP cranial view on the left panel, quite a bulky, hazy mid-LAD lesion adjacent to quite a large diagonal side branch. On the AP cranial, not a dissimilar appearance. And so it's certainly consistent with the stress echocardiographic findings. So in a patient with unstable angina, we proceeded to imaging-guided PCI. Using our co-registration system, we pulled back across this bulky lesion and back to the left main, and we could see there's a large bulky plaque at the diagonal. It's fibrotic. You're going to see it now coming back in the mid-LAD across the diagonal, catheter hugging, fibrofatty plaque, very little calcium. So using the co-registration images, we could plan our procedure. We've got a distal reference segment beyond the diagonal, around 3.7 millimeters, proximal reference in the ostial proximal LAD near to 5 millimeters, a lesion length of the order of 16 millimeters. So we could plan our procedure. IVUS guidance, we've got our reference segments. We chose a 3/5/80 millimeter onyx stent with a provisional strategy, angiographically a 100 lesion. We planned to pot. We've got quite a lot of length from the carina back to the left main for an 8 or 10 millimeter short NC balloon with a 4/5 millimeter balloon and distally optimized with a 3/5. So that's what we did. 2 wires, LAD diagonal, prepared with an undersized balloon, 3/5/80 millimeter onyx stent, pot with a 4/5 short non-compliant balloon, exchanged our wires, and then kissed, sizing our balloons, as you've heard, to what we thought was our reference segments distal to the bifurcation, a 3/5 and a 3, and a final pot with a 4/5 millimeter balloon. So the stent enhancement images show you've actually got good scaffolding with the provisional strategy at the ostium of the side branch. When we do these procedures, bifurcations with POT, we really need to understand, particularly when we've got size discrepancy between the mid and the proximal vessel, what our expansion capabilities are of our chosen stents that we have in our inventory in our cath labs. And this is the Onyx stent, the 3.5 on label can go to a 4.75, the largest iteration up to 5.75. There is data from engineers, Nicholas Fine, that we can actually off label take these stents to bigger size. So angiographically, having performed a POT, KISS POT, we were quite comfortable with the angiographic result. We performed imaging, which is very important for all the reasons we've discussed. And to our surprise, despite quite reasonable sized balloon, we had significant malexpansion and malapposition very focally in the LAD distal to the side branch. Is the lumen, is the stent. And at the ostium of the stent segment, it's still malexpanded, particularly for a very large reference segment and some malapposition in addition to malexpansion. So really, I guess we knew what our reference segments were. We'd been a little lean, so we further optimized with a KISS with a 4mm balloon in the LAD, 3mm balloon in the side branch, and repotted with a 5mm balloon in the proximal segment. Providing a good, again, final result angiographically, a little bit of pinching in the diagonal, but the patient's asymptomatic, has normal flow, normal ECG, very comfortable with the provisional strategy here. Then we performed our final imaging, and we're now very comfortable. We've got a good result in a high bleeding risk patient about to undergo urology surgery with a nephrectomy. Distal reference, we've got good expansion in the distal segment, over 10mm squared MSA, reference to our distal reference. To the area of concern, we have now sort of 13mm squared, back to the very proximal stent segment, almost 14mm squared. So a very good angiographic, but more importantly, IVUS result in this scenario. And this coincided in my country in Australia with our regulatory body, the Therapeutics Goods Association, providing a certificate for Onyx for 1 month of dual antiplatelet therapy in high bleeding risk HBR scenario patients, as this patient was. And this data was based on the Onyx 1 randomized trial, 1-to-1, 1,000 patients receiving the Onyx stent compared to 1,000 patients receiving the Biofreedom drug-coated stent from the Leaders Free trial, the original high bleeding risk study when the Biofreedom was compared to a bare metal stent, followed for 1 to 2 years. Inclusion criteria, many of them, over 60% were elderly, almost 40% oral anticoagulation, and then a mix of high bleeding risk criteria such that 1.6 average criteria per patient. 46% of patients across the study had 2 or more criteria for high bleeding risk. Primary endpoint, the composite of cardiac death, MI, stent thrombosis, 2 years, non-inferiority was met. With the so-called market-leading device based on high bleeding risk from a device point of view. But importantly, and not surprisingly, with the thinner strut stent, significantly lower spontaneous MI at 1 and 2 years with the Onyx over the Biofreedom, and lower clinically driven target lesion and target vessel revascularization. So I think it's an interesting case. I think it illustrates the issues that we should consider in high bleeding risk patients. Particularly, we need to consider the definitions of high bleeding risk, both clinically and from a trial point of view, and adapt our bifurcation technique, particularly the role of imaging optimization, help to make it safer for a shorter period of dual antiplatelet therapy. So on that note, I'll stop, and I'll thank you for your interest in this case, and hopefully we've got time for discussion.
Okay, thank you very much, Dr. Jeffson. Dr. Jeffson introduced a short duration of DPT duration in high-risk bleeding patient, and he introduced especially Onyx 1 study. So I'd invite panelists for comments and questions. Dr. Jung-Soo Kim.
Thank you for providing useful knowledge through the interesting and direct cases. So as demonstrated by the four speakers, I think the Onyx stent is a very good option for clinically or anatomically complex situations, such as bifurcated or calcified ostia or high bleeding risk patients. So I have one question for the Dr. Minami. Is only the telescope is capable of OCT penetration during the procedure, or is it not possible to using the guideline or guidezilla?
Thank you very much for your nice question. If you use the guideliner or guideliner, the OCT light can penetrate through the only tip of the guide extension. On the other hand, if you use the telescope, OCT light also can, penetrate through the shaft of the extension. So, for that kind of also case, telescope is much better than other tools.
Do you have any experience telescope using in a left main ostium also?
Yes, sure. But if the diameter of the left main is quite huge, it's a little bit impossible or difficult to remove the red blood cell surrounding the tip of the guide extension. So the right ostium is the most, the suitable for this kind of technique.
Okay, thank you very much.
Thank you.
Dr. Young Min-woo.
Thank you for all lecturers for nice presentation. And I have a question to Dr. Oh. It's a simple question. I prefer transfemoral intervention using 7 or larger guiding catheter to main bifurcation lesion, but some people who likes intervention through the transradial, they said it's 6 French is enough to intervention of left main bifurcation or LAD bifurcation. How do you think about that?
Yeah, that's an excellent question. I'm also wondering about that myself. In my clinical practice currently, I am doing about 50% of my left main bifurcations with transradially with the 6 French. But it is, the one thing is for sure is that it is much more easier. The procedure, for me at least, the procedure time is much more shorter when I go transfemoral and get a 7 or 8 French in there, because we're going to kiss, and we're going to have to put the stents in. It's very important to have a great, well, if it's not really a left main os disease, it's very good. I usually go for EBU catheter also. So it's with very good guiding support with the femoral compared to the radial approach, especially when there's a very old age patients with the tortuous subclavian artery. So, but it is possible to do the transradial approach, and it is, well, the results are all the same. It's just that for the physician, it's much more harder for him psychologically and physically. That's in my experience. I don't wonder how the other panelists think about this.
Okay, thank you very much. I'd like to ask about Japanese and Australian experience. Dr. Minami, do you prefer transradial approach for left main bifurcation lesion?
Yeah, sure. Yeah, I'm always using the transradial and using the 7 French guiding catheter. And
7 French. Okay.
Yes, yeah. I'm not sure you have the glide Cs. If we use glide Cs, outer is a 6 French and inner is a 7 French, so we can use the guiding, 7 French guiding catheter without any further injury to the right radial artery.
Okay, some patients have small radial artery in Korean patients. So how do you overcome the small radial artery in Japan?
Yeah, me too. Yeah, but yeah, just the training, and discipline. The distal radial approach is my favorite, and yeah, my standard style.
So you can use a 7 French in distal radial.
Yeah, sure.
Oh, really? Okay, thank you very much. How about Dr. Jepson from Australian experience?
Yeah, certainly in recent years, there's been a big transition from femoral to radial for intervention across the board. And I think that includes left main as well. Certainly, many of our patients are bigger size, so as with Dr. Minami, we feel comfortable using 7 French guides for a lot of our patients from the radial approach to overcome some of the issues, with kissing balloons and imaging, and to prevent the resistance. So yeah, it's probably my own practice. It's probably 50-50 femoral radial for left main intervention as a ballpark figure.
And cardiac surgeon recommend transfemoral approach in patient, especially CKD. So, Dr. Minami, do you prefer in transradial approach in patient, even in patient CKD?
Yeah, sure. Yeah, always. I think the most Japanese doctors, they prefer to use the transradial, in almost all the patients, irrespective of the renal function.
Okay, thank you. And Dr. Young-won Yoon?
Yes, I think in my experience, I usually do almost all radial cases and almost always use 6 French guiding, whatever, left main, bifurcation. 6 French is, I think, enough for doing
and CT also.
CT also, but
okay.
just not for the rotablation. It needs 7 French. So I sometimes encounter the lesion should be rotablated. Then I do the femoral puncture again, but not other than that. I usually use all 6 French guiding. Can I ask one question about the supporting power of the catheter to Dr. Minami? The extension catheter. The supporting power is how is the supporting power compared with Geisinger or Guideliner?
Thank you very much. Actually the telescope is more the hydrophilic. So we can more easily pass deeply through into the the tortuous or calcified vessels. So I prefer to use the telescope. I'm not sure the difference in the the power of the assist power, but we can more deeply insert the telescope to the distal through the tortuous artery.
Okay, thank you, Dr. Minami. So please come to Korea, bring your catheter and telescope. Okay, any other communications? Okay, thank you very much for excellent discussion and excellent talk, especially from Japan and Australia, Dr. Minami and Dr. Jackson. I hope Onyx will be the best stand for bifurcation lesion. So I cross that symposium. Thank you very much.
Bye.
Thank you very much.
Thank you.